Greetings, everybody. I am going to go through the radiation safety aspects in the medical management of radiation casualties. My name is Soma. I'm the Senior Principal Medical Physicist at the Department of Nuclear Medicine and Molecular Imaging of Rad Science Division at SGH. I'm also the Radiation Response Team Chief as well. Without any further ado, let us go on to today's lectures. Basically, the contents and the objective of my talk are listed over here. I will provide guidance for healthcare workers regarding radiation safety in the management of acute radiation syndrome patients who are internally contaminated with radioactivity. So what I will do is the contents of the presentations are as such over here. We'll talk about the background information about radiation and how we measure radiation. Then we'll talk, chapter 3, we will talk about radiation safety while managing internally contaminated acute radiation syndrome patients, how we monitor radiation, as well as the general precautions handling of waste and spillage. Before we'll talk about some miscellaneous aspects and then we summarize. The first chapter that I want to talk about is the background radiation on radiation. And radiation is everywhere, all around us. We get our radiation exposure from the sun, from the ground, from the earth. The materials, the building materials, contain some naturally occurring uranium-238 and especially thorium-232 as well. So we do get our radiation from the ground, the food that we eat as well. Certain foods such as bananas actually concentrate a high proportion of potassium-40, which is radioactive, and of course carbon-14 is found in all of us as well. So this is basically how the radioactivity enters the food, the human beings as well as animals through the food intake and the water we drink as well. In some countries, in the northern European countries, we can also breathe in radon gas as well, which comes into and stays inside the lungs as well. So, but Singapore not so much as that, because we have granite rock under the ground and there's not much radon gas. At the same time, there's a lot of air exchanges as compared to northern European countries during winter. Now, if I can take banana as a natural source of radioactive isotopes, eating one banana will actually gives us about 0.1 microsieverts of radiation. That's because of the potassium-40 that is contained in the banana. This is a rough gauge, and so there's nothing that we need to fear about radiation, because radiation and radioactivity exist in nature and they exist in our body as well. And we do irradiate people who are very close to us as well because of the radioactivity that we contain in ourselves. This is a little table which actually talks about how many bananas are equivalent to fetal dose death within 2 weeks of about 100 million bananas. So for example, if you go down the list here, 700 bananas are equal in radiation to eating 700 bananas is equal in radiation to living in a store, brick or concrete building for 1 year. So that's the kind of radiation that we receive from the building materials, and that's equivalent to 700 bananas, eating 700 bananas or so, right? The annual background radiation varies from country to country, and it is about 2,000 to 3,000 microsievert of radiation in Singapore. Whether you live in Yishun or whether you live near SGH, it doesn't matter. It's about the average of 2,000 to 3,000 microsieverts of radiation per year. And in some countries, they can go up to about 10 times this value as well. In some areas where the natural radioactivity is high because of perhaps the altitude as well as the soil contains more radioactivity. Right. So now in this slide, let's see how we can measure ionizing radiation. As the body is exposed to radiation, energy is deposited inside the body. Radiation basically is a form of energy transfer, right? So the radiation exposure, or in some books they call it as dose equivalence, is measured in a unit called sievert. This is a unit that we use to measure radiation. It's a very large unit, and generally in the hospital setting we will be looking at microsieverts or millisieverts. So the radiation exposure is basically the measure of the energy, radiation energy transferred to tissue basically. Right? So ionizing radiation has no mass, and it has no charge, and it is colorless and odorless. That means you cannot smell radiation, nor can you feel any heat coming out of the radiation as well. Okay, therefore we need to use an instrument such as this. It's called a radiation survey emitter, to help us to detect as well as measure the radiation that comes out of a patient, for example, or from an instrument or a room. Alright, and now this lady is actually measuring the radiation exposure from this staff who had worked in the Fukushima nuclear power reactor many years ago in Japan. Now this slide here basically talks about the differences in different types of ionizing radiation. On the left hand side you have the non-ionizing radiation, where you have the EMF, the alternating current, as well as the radio waves, as well as visible light. That is all form of a non-ionizing radiation, whereas the focus of today's talk is going to be about the ionizing radiation, where gamma rays and X-rays are basically examples of ionizing radiation, right? So that's what we're going to talk about in the next few slides. Now, what do these RSM or instruments that are used to measure radiation, what are they meant for? Well, they are used for detecting and measurement of radiation. They detect and measure beta particles, gamma rays, and X-rays radiation, and they help us to measure the radiation exposure from a patient, as well as what the staff is actually trying to do some measurement on a mannequin. The location of radioactive contamination basically is to detect the surface contamination. For example, if the bio fluids of a patient who's contaminated with radioactivity, if it spills on the floor or on a treatment trolley or syringe pump, etc., this sort of instrument helps us to detect whether the instrument is contaminated with radioactivity, right? And of course, it also helps us to do screening for environmental contamination. Example, the urine bags, etc., catheters, etc., if they are contaminated. Now, one important point that you want to remember on this slide is the surface of the object that is considered to be contaminated. If the radiation exposure measures 1 microsievert per hour. So do note that this instrument, this RSM instrument, basically measures in terms of microsievert per hour. So it's a rate. It's a bit like, just like velocity, which is kilometers per hour, right? Just like that, this instrument measures a rate, and that is basically the radiation exposure, which is microsievert per hour. All right, so as long as greater than 1, then it's said to be contaminated. So the background radiation, as you switch on, as you can see in this instrument, it's about 0.44 microsievert per hour. This background is about 0.2, 0.4 microsievert per hour. But if it reaches 1 microsievert per hour, then that whatever you're measuring may be contaminated. Right. So these are some buttons in which we can actually look on the survey meter. How do you switch on this survey meter? It's a one-hand operation. There's an on button. You just keep it pressed for a few seconds and it switches on. It makes a bit of noise, and then it does some system test, and then it can be utilized already. Within 10 seconds you can start using this survey meter to do various measurements. Now, if you want to switch off the machine, there's 3 short presses on the off key. So it's not very intuitive. This left arrow button, if you press it 3 times, it will switch off the instrument to conserve battery. There's a little button which cannot be seen on this photograph at the top here. It's a toggle button. If you do a short press on it, the sound disappears. So sometimes if you feel irritated by the loud sound, all you have to do is just press this button and it will silence the survey meter, but it will still be measuring the radioactivity as well. Another picture of the front of the survey meter with the units in gray is reached 0.09 microsievert per hour. Okay, that's the unit that is being measured, and this looks like it's background radiation as well. That detector is on the reverse side of this. This is the back side of it. This is where the grating is, and this is where the detector is. Generally, this sort of survey meter can be contaminated if it touches contaminated radioactivity. So what we do is we put this into a Ziploc or a plastic bag and seal it with Scotch tape so as not to contaminate this survey meter, because in the event that the plastic bag or Ziploc bag gets contaminated, you can just replace it, right? The instrument is still clean and can be utilized for radiation detection. There's a little compartment over here that this photograph cannot see very well, but if you look is near this portion of it, the reverse part of this, where you have a battery compartment where we can replace the battery with a AAA battery. Right, there is a video
Radiation
which I
survey
will
meter
show
RSM.
you
Switch on
about how
the
to
survey
use
meter.
the survey
It
meter, but
beeps to
I have
ensure
not
that it
included in this
is
PowerPoint
working, is to show
presentation
you that it's
because
working.
of the fact of the
And
size is
you
very
will see the
large,
background
and it can be
radiation is
found, it can be
0.1
found in
microsievert per
the
hour.
Visilearn as well,
So I'll
which
bring
we
it
will
closer. I
provide
don't
a
know whether
link
you
for
can
you.
see it. Okay, all right. Now I'm going to survey two areas over here. As you can see, these two blue spots, and to see whether there is any radiation. So let's do this part here, and I'm moving around here. It shows about 0.13. This is still background radiation. Let me put it in the right way. As you can see, 0.13 microsievert per hour. There's no radiation. Let's look at the other blue spot. Oh wow, there is some radiation. So this is what the patient will be. Let me switch off the sound, and so that you can hear me. This is basically we are reading something like 2.4 microsievert per hour at 5 centimeters away. So just imagine if that was your patient, that's the 5 centimeters that you will be measuring the radioactivity of. The cutoff is 10 microsievert per hour, right? So if you have never reached that sort of levels at this distance.
Now, next we will look at what is this acute radiation syndrome. ARS is short form for acute radiation syndrome. As nurses, you would know, acute perhaps refers to uh, 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 high levels of radiation subjected to a patient or a casualty over a very short period of time, and that's why the word acute is used here. This ARS basically also known as a radiation sickness or poisoning, or some books call it as radiation toxicity, is an acute illness caused by either irradiation of the body or internally contaminated by high dose of ionizing radiation over a very short period of time. This period of time could be a couple of hours, or it could be 1 or 2 days, etc. So within that short period of time, the body is unable to overcome the ill effects of the radiation, and the body succumbs to ARS. Right? So these ARS casualties generally arise from the following categories. They can be either internally contaminated with radioactivity, or they have received an external radiation exposure. Now, what do you mean by external radiation exposure? Well, as you can see in this Venn diagram, this red Venn diagram, this portion here is purely external exposure. Now, when you send your patient for a CT scan, right, or a chest X-ray, this patient goes to DTR or DVIR, and they get a radiation exposure. right? This is called external radiation exposure. The patient is said to have received an external radiation exposure from either the CT scanner or the chest X-ray, or for that matter from the portable X-ray that is used in ICU or the wards. Right? So the upper portion of this Venn diagram is the blue ovals here. Here it says internally contaminated. So the upper portion of this is basically purely internally contaminated. And of course, as the subset of these two Venn diagrams, it's this portion here, which the casualties have got both external exposure as well as being internally contaminated. So not all ARS casualties will have radioactivity contamination. All right, because they could have been exposed to a high dose of radiation. We are talking like the radiation from 1,000 CT scans, for example. All right, that kind of levels of radiation can give rise to a ARS, and this sort of casualties will have been exposed to very high levels of radiation, but they are not contaminated with radioactivity, because after their exposure, they are as clean as any other patient. They don't have radioactivity inside them, but they had sustained a radiation exposure, and that results in an acute radiation sickness for these casualties. So these ARS patients who have received external radiation exposure are not radioactive and can be managed as critically ill patients in SGH. In general, these patients do not pose a significant radiation hazard to our staff. Radiological risk is similar or lower than the biological hazard risk resulting from ordinary medical practice, while, for example, looking after an MRSA patient. Okay, now we are going to talk some more about irradiation versus contamination. And of course, when you have contamination, you can either have internal contamination or external contamination. Now, irradiation, as I mentioned in the earlier slide, the patient receives either a whole body or partial body radiation, similar to a CT or X-ray, as I had mentioned in the earlier slide. There will be zero hazard, radiation hazard, while we attend to such a patient at SGH. Okay, once they have been exposed perhaps in a nuclear power plant, when they come to SGH, they are clean and they do not contain any radioactivity inside them because they were externally exposed. Now let's talk about contamination. As you can see in this slide here, contamination has got two types. One is external contamination and the other is internal contamination. So in very quickly, the internal contamination is when radioactivity has entered the patient's body. All right, it has maybe manifest itself inside the heart or the bone of the patient, and it is not going to come out of the casualty. Whereas external contamination is when on the radioactivity that is found on the clothing or this outer clothing of this casualty. Now that is quite easily removed, because once you remove the outer clothing, the 90% of the external radioactivity would have been removed. Okay, and then only 10% may be found on the hands, that is does which there are no skin, there no clothing, or perhaps on the face or at the back on the hair as well. That's where the 10% of radioactivity may have fallen on for externally contaminated casualties. Okay, now these casualties are unlikely to have ARS because they only have contamination on the outside, and upon removal of their clothing, they are clean. At the same time, they are not likely to receive very high levels of radiation, and hence they wouldn't have ARS. Whereas internally contaminated casualties, if the radioactive material is either inhaled, swallowed, or absorbed through cuts and bruises on the skin, and the radiation exposure and dose depends on the kind of radioactivity that is contaminated this casualty. Okay, there are some radioactivity such as that is found in the nuclear medicine department in various hospitals like technetium 99M or fluorine 18. These are used for nuclear medicine imaging. Now this sort of contamination with such short-lived radionuclides will not pose a high radiation exposure to this patient, because after 1 day or maximum 2 days there won't be any radioactivity inside these casualties or patients. Whereas if the casualty is internally contaminated with radionuclides such as cesium-137 or cobalt-60, that would result in a much higher level of radioactivity, and that would have stayed inside the patient perhaps for many years, and that would pose a higher radiation exposure to the casualty. Right. How do we protect ourselves from radiation? Well, there are three principal ways in which we can do that. One is to use shielding. That is what we can see our radiographer colleagues. They often wear lead apron when they do a portable chest X-ray or for your patients in the ward or ICU. And the other is time. So you want to reduce the time to reduce the radiation exposure that you will receive from a patient who perhaps is internally contaminated with radioactivity. The other way is distance. Distance is a very economical way of reducing our radiation exposure. Now this distance is basically, if you increase the distance by 2 times, the radiation exposure actually drops by a factor of 4. So sometimes some books call it as the inverse square law of radiation exposure and the distance, right? So this, just remember that distance is, if you take one step back away from the radioactive patient, your exposure would reduce drastically as well. Now, next we're going to talk about monitoring. How do we monitor radiation exposure? This instrument, which looks like a very small handphone, uh, is called electronic personal dosimeter. So in short, it's called EPD. So this is basically something that we can wear at our waist level, or we can hang it around our neck like a lanyard, or we can put in our shirt pocket to detect and measure the radiation exposure that we receive from a patient or from an instrument or from an X-ray machine, for example. Right? So this is basically the unit is microsievert or millisievert, the total accrued or subjected radiation exposure, and this helps us to detect how much radiation we receive from a patient, for example. And there's a limit that we put, and it is called 1 millisievert is a limit that we see. Once it reaches that, it starts to beep, and when that beep comes up, when you hear that beep, what you need to do is finish up your work slowly. If you're attending to a patient halfway, complete your task, and then report to your supervisor saying that you have reached this 1 millisievert of radiation. Now, ladies and gentlemen, 1 millisievert is a very large unit. It takes a long time, maybe a couple of days, to reach that sort of radiation exposure in general. Staff are advised to stand further distances as possible when we are delivering care. This is basically what we spoke about just now as the inverse square law, or the distance which helps us to reduce the radiation exposure. Let us see how we can switch on and switch off this electronic personal dosimeter, or EPD. When you see the word pause on the screen, this small little screen, what you need to do is press the plus button. The plus button is over here on the right hand side when the screen is facing you, and there's a negative button on that side. Okay, they are both rubberized, and once you see the word pause, you keep it pressed with your fingernail on this plus sign until you see the word enter, right, come on screen, this electronic screen. And when you see the word enter, you quickly remove this finger that is pressed on the plus, and quickly press the negative button. So when you see that, and automatically it comes to run. Okay, and then you can start using the survey meter. And switching off is vice versa, the same way. Okay, right. There's a close-up view of how the screen would look like, as it currently shows 20 microsieverts of radiation. Right. Your ward will have these sort of hard copy forms where we can actually record the radiation exposure that you have been exposed to during your shift. For example, your 8-hour shift or 7-hour shift, when you're working, attending to these patients who have got contamination inside them. Um, you would be needing to write your name, your designation, the shift that you worked on, the start time of the shift and end time of the shift, and the total amount of exposure that is read on the electronic personal dosimeter. So, and then this EPD can be recycled, can be reset and recycled, and another staff, another colleague of yours in another shift can use it. So after a day, when you come back the next day for your shift, assuming there's the same time of the shift, you start using the electronic personal dosimeter and write the next entry, right? So that's basically a simple form to help us to determine what is the total radiation exposure you have been exposed to.
Recommended time limit spent in proximity to radioactive patient. Allow the patient to lie supine. Use a radiation survey meter such as this. Take the distance where from the body of the nurse to the patient's body. If the distance is 0.5 meters, take the radiation survey meter reading at that distance. Let's assume that the radiation exposure is 1000 microsieverts of radiation per hour. That would imply the nurse can spend as much as 5 hours at that distance from the patient. Let's assume another example where the radiation exposure is low at 10 microsievert per hour at that distance away. That would imply that you can spend as much as 500 hours at that distance from the patient because the exposure is lower in this case. Following from the earlier slide, let's look at this example. A patient with internal contamination is warded at Ward X at SGH. If the exposure rate of the patient at 1 meter is measured to be 50 microsievert per hour, what is the maximum time that a nurse can assess this patient? The patient can be handled at 1 meter for suggested maximum time of 100 hours. How do we get this? From the table from the earlier slide, 5000 microsievert per hour divided by 50 microsievert per hour gives us 100 hours. Similarly, example 2, where we has got a patient is measuring slightly different or double the radiation exposure of 100 microsievert per hour at 50 centimeters away this time. What is the amount of time that the nurse can spend with this patient? Here we take the numerator as 5000 microsievert per hour, divide this by 100 microsievert per hour, that's the rate that is determined, and it works out to be 50 hours over.
Next, we're going to talk about general precautions, handling of waste, and general precautions in handling internally contaminated ARS casualties. Now, these patients, mind you, have got some contamination, radioactive contamination inside them. They may be discharging it, or they may be not discharging this radioactive contamination. Nevertheless, the treatment is similar. Wear your EPD at all times when you are attending to these patients. The EPD alarm, if it rings at 1 millisievert of radiation when it reaches during your shift, what you need to do, finish up your tasks for that particular patient, and then alert your supervisor to find a replacement staff to look after that same patient. Pregnant staff shall not be assigned to manage these ARS internally contaminated casualties if the radiation exposure is high. And what level is that? Well, if it is greater than 80 microsievert of radiation at 1 hour, at 1 meter away from the patient. Always use PPE when handling body fluids. This is because some of these internally contaminated ARS casualties may be discharging the radioactivity through their body fluids. Where possible, no food or drinks until after decontamination of hands has been performed to minimize the risk of you being internally contaminated. To provide disposable cutleries to the patients and discard the food waste with disposables in general waste. Now, if you have some of these casualties who have MDRO, infected ARS patients, which is a possibility, they should be handled according to infection control guidelines, okay, which will not be covered in this particular presentation. Prevention of internal contamination. There are three ways in which we can contaminate ourselves when we handle radioactivity, or when we nurse patients who have got radioactivity inside them. It's through ingestion, it's through inhalation, as well as if you have cuts and wounds on your hands and you attend to these patients without proper PPE, there is a possibility of contaminating ourselves. And of course, this can be avoided by safe and good practices, by wearing PPE all the time when you're dealing with patients and their body fluids, practicing good housekeeping, clean work habits, and of course, frequent hand washing. Now, nurses, what works for COVID-19 will certainly work for this group or cohort of patients who have got ARS and are also internally contaminated with radioactivity. What kind of PPE do we use? There is no need to use lead gowns, but rather the usual universal PPE such as surgical mask or N95, depending on the COVID status of the patient, over boots or over soles, cap, double gloves. Now the reason for double gloves is because what if the inner gloves breaks, what if the outer glove breaks or tears, the inner gloves will still keep your hands contamination free, and that's the purpose of that. Handling of body fluids from internally contaminated ARS patients. Any excreta may be disposed in the normal manner and the bedpan returned to normal service after cleaning in the usual manner. For example, some of these patients may need CRRT. During CRRT, once the urine bag is filled, it can be emptied into a designated sluice in the disposal room, for example, in an ICU setting, for example. If the patient should vomit or urinate, etc., any soil linen could be contaminated. So wear PPE as usual. Soil linen and pillowcases and diapers, for example, are placed in plastic bags within the appropriate receptacle inside the room. So, for example, when I mean appropriate receptacles, is say if it's general waste or biohazard waste or infectious waste, okay, that sort of receptacles. RRT, or that the radiation response team members, are basically people who have been trained to use these radiation survey meters and know how to interpret the radiation readings, and hence they will be able to monitor the waste daily and instruct if it is safe to discard as general waste. Okay, so because we can't say that all the patient's waste is going to be either contaminated or not contaminated, so it varies patient to patient, and hence RRT shall monitor this and mention if for Mr. Tan, who is the patient, his waste can be disposed as general waste or it needs to be stored in a separate room. The RRT will monitor the situation and determine if the housekeeping services can be carried out in that particular room. This is a picture of how a CRRT dialysis unit in a ICU setting. Um, and as you can see, the urine bag gets filled up and it can be used. It can be emptied into the sluice. Um, Additional contamination control. In addition to the PPE worn by the staff, bits uh, could be prepared by lining them with these blue sheets so that they, these ARS patients who are internally contaminated and not externally irradiated, if such internally contaminated ARS patients, because of their body fluids, it'll be good to line these blue sheets under their bed sheet. The radioactive spill kit is basically a little Tupperware box which contains the usual regular items, and they basically have this is the checklist basically: soap solution, regular liquid soap solution, gloves, signage, radiation signage sign, which is not very evident from this photograph here, but basically it's got the radiation hazard sign on it. The usual wipes, the sponge, blue sheets, absorbing sheets, masking tape of two different thicknesses, PPE gown, surgical mask, Ziploc cable tie, and radioactive waste bag is seen at the back here. Now these are regular items that you can have in the ward, but the reason why we put them all together in this little Tupperware, that is side profile is shown over here, is because for quick access and you can get this and attend to any body spill. Management of radioactive spill. Nursing staff should clean up as much of the spillage as possible using the following procedure. If a spill arises from the patient's body fluid, treat it as radioactive generally, also only for internally contaminated ARS patients. Alright, staff to wear PPE, body fluids, for example vomiters, may be disposed into the common toilet or disposal room with a double flush to ensure removal. It is preferable to use disposable urinal or bedpan, or otherwise dedicate a jug or bedpan strictly for patients' use, and this is the radioactive patient. A checklist such as this is available inside the spill kit. At the same time, it can be also accessed from the 60720 WRM 605 Management of Radioactive Spill from the ward. These are my telephone numbers and my colleagues as well, who you can reach, and they're all part of the RRT team, and you have any queries you can ask us. Um, let's go through the management of radioactive spill. This is a spill kit as I showed you before. If there happen to be a spill, for example, this is on the floor, what we need to do is open up the spill kit, mark out the spillage area with a 1-inch masking tape so that you know where the contamination is, and then you soak up the radioactivity by means of disposable paper or towels, and then once that is clear, you want to clean out to in. Now the reason why we demarcate is because at least we know, because once the spill is removed, you can't tell where was the spill, right? So that's the reason to demarcate this area. Okay, and then you start to clean out to in. The reason you want to do in this fashion is so as not to increase the spill site. Now this is what you would do for a biohazardous spill as well, right? Not to increase the surface area of the spill site. And of course treat the soil, towels and wipes as solid radioactive waste. Continuing with the management of radioactive spill, discard the soil, towels, wipes into the plastic Ziploc bags before disposing into the radioactive waste bag. Cover the spill area with these blue sheets, such as this example shown over here, with the plastic side facing up. That means the blue portion or the yellow portions facing upwards. So the absorbent part is actually touching the contaminated site. Next, inform Environmental Services Supervisor about the contamination. The RRT will follow up and advise accordingly when the terminal cleaning could be done by Environmental Services. Document in the checklist that you had actually followed all the steps one by one. Replenish the spill kit as you may have used up some of the items in the spill kit. Right, next we look at the last portion of this talk, and that is the miscellaneous and handling of laboratory specimens. For externally contaminated and internally contaminated ARS patients who do not discharge radioactivity. Okay, this is something an RRT member can confirm for you. Handling of the laboratory specimen would then follow as per standard procedure, and standard precautions shall be exercised. For internally contaminated ARS patients who discharge radioactivity, that means their body fluids contains radioactivity, in such category of ARS patients, of course again confirmed by our RRT members, um, they have a little table that we will help you here. If the exposure rate at 5 centimeters is less than 10, handling is as per standard procedure and standard precaution, as you send these blood tubes for blood workouts in pathology department. And if the value on the exposure rate at 5 centimeter using a RSM meter, if it happens to be 10 to 199, you double back the specimen and affix the radiation signage, which is found inside the spill kit. Place this one of these onto the plastic bag, and if the value is between 200 and 999, RRT shall assess this staff radiation safety and arrange for the transport of such blood tubes. If the value is greater than 1000 and it's not suitable to send to pathology laboratory because of the high level of radiation for assays, and shall be managed by the RRT members as well. Okay, so you would be working with the RRT member quite closely for the assessment of the radiation exposure outside these blood tubes. Handling emergencies in the event that hands or outer skin surfaces are contaminated, wash with soap and water, paying particular attention to areas around the fingernails, between fingers, and on the outer edges of the hands. This is similar to when you are doing any form of decontamination after handling a biohazardous patient. For the eyes, wash thoroughly under running water in the event of some contamination. Inform RRT accordingly, as the contaminated areas shall be measured with radiation survey meter. In the event of after office hours, collect your survey meter from Ward 72 if your ward does not have one. In the event of a cardiac arrest, no mouth-to-mouth resuscitation shall be used. The event of fire, following evacuation, these patients shall be kept 1 meter away from other patients and staff at the gathering point. This is once again to reduce the other people's radiation exposure. In the event of a death of an internally contaminated ARS patient, notify RSO, which is myself, for further advice on the management of the deceased. The procedure for the last office is to be performed with principles of radiation protection by 2 nurses wearing full PPE, double gloves, and shoe covers where necessary. The body shall be clean, similarly to a non-radioactive deceased patient. All orifices are to be carefully packed. Radiation spillage sign shall be pasted onto the 3 yellow and blue hard copy identification cards and death checklist. Write a summary of the patient's condition and the radionuclide and the last radiation reading onto the death checklist as well. The mortuary team, porters, and the general service staff are to wear the usual PPE so as to prevent contamination, and be informed of the radiation hazard by the ICU or ward staff. These two SOPs basically give us more detailed about the radiation safety as well as guidelines for the management of nuclear medicine patients in an ICU setting, while this form was described earlier to you on the management of radioactive spillage. And these documents basically are based on the radiation protection regulations of Singapore. There's a particular chapter, chapter 11, on the title The Management of Radiation Casualties. Uh, Basically describes the principles of medical treatment and the management of radiation casualties, including ARS casualties, located in the Emergency Response Plan at the SGH InfoNet. These manuals are based on the SGH Campus Civil Emergency Radiation Dispersal Device Response Plan 2017. These are the subtopics in this particular chapter 11. The SGH management of radiation casualties with ARS basically can be managed according to this flow chart. In summary, radiation and radioactivity is natural and can be found all around us. Patients with acute radiation syndrome may or may not be internally contaminated with radioactivity. The radiation exposure you are expected to receive in handling internally contaminated ARS patients is expected to be low. Nevertheless, any radiation exposure carries a risk of incurring radiation-related illnesses, and this risk is very small, and on average, the risk we encounter in other activities or occupations that we consider safe, like walking across a heavy traffic road, carry a higher risk than that from radiation. The best approach is to always keep your radiation exposure as low as reasonably achievable, or ALARA in short, using PPE, thus ensuring the contamination control from body fluids of internally contaminated patients, following SOPs as mentioned in this presentation, adhering to the shielding time and distance approach to reducing the radiation exposure to ourselves. And if at any time you are in doubt, please approach your supervisors, the radiation safety officer, myself, or the radiation response team members for advice and for clarifications. I wish to thank you for your patience and in going through this presentation. There are some quiz questions to assess your understanding of this topic, and my contact number and the email address is here. And if you have any doubt in regards to the presentation, please feel free to write to me or call me. Thank you very much.